Good evening, sir. Good evening, sir.
We're good to start, sir.
Yeah. Good evening, everyone. Welcome to master classes in critical care medicine from Yashoda Hospital. These classes we are conducting from since last 4 years. So to present the interesting case on oncological emergencies, today we have students from Yashoda Malakpet Hospital. Dr. Sachin, he is DRMD student, and Dr. Jeevan, he is IDCCM student. And to take the case presentation, we have senior faculty and seasoned examiners, Dr. Sudipta Mukherjee from he's head of the department critical care medicine from Tata Medical Center, Kolkata. And another examiner, Dr. Anand Joshi, he is a Australian returned physician and intensivist, presently working in Raman Hospital, Hyderabad. Dr. Sachin and Jeevan, you can present the case.
Good evening, sir. Good evening, sir. I am Dr. Sachin.
Go.
53-year-old male patient came with complaints of shortness of breath, facial puffiness, recurrent syncope, dry cough, and generalized edema. History of presenting illness. Shortness of breath since 10 days, insidious in onset, gradually progressing from grade 2 to grade 4. Associated with dry cough, generalized spitting edema, and facial puffiness for 1 week. Syncope for 20 to 30 seconds, recurrent since 2 days. No history of seizure, chest pain, palpitation, fever. Past history. He is a known case of atypical carcinoid mediastinum diagnosed 2 months back on octreotide and capacitabine therapy. He is a known case of diabetic also. Personal history. He is a police officer by profession, non-smoker and alcoholic. Family history, not significant. On examination, airway was patent, no striders. Breathing, respiratory rate was 28 per minute. Saturation, 88% in room air with a face mass of 5 liter O2, improved to 96%. Right-sided air entry was reduced in inframammary, infraaxillary, infrascapular areas. Circulation, BP was 90 by 50 mmHg and pulse rate was 120 per minute, regular volume, pulses, paradoxes was present. JVP was elevated 7 centimeter above Lewis angle. Muffled heart sound on auscultation. TRBS was 112 milligram per deciliter. Moving all limbs, pupils was bilateral, 3 mm and reactive. Temperature was 98 degree Fahrenheit. Pallor was absent. No icterus, no cyanosis, no clubbing, no lymphadenum. Generalized spitting edema present. General examination. Patient is moderately built and nourished. Facial puffiness present.
Can you hold for a minute? So when you're presenting your case, just try to have one pattern. You went from airway, breathing, circulation, disability, exposure. Now again you're going back to examination and the systemic exam. You're going to repeat 2 things. So don't go both the things. Adopt one method and stick to that. Otherwise it will be more confusing. You'll see that. Go ahead. The same thing you are repeating now, right?
Yes.
Same thing here.
Systemic examination, seen as conscious and oriented, GCS 15 by 15, moving all forward. Respiratory system, bilateral chest movements are symmetric and regular. Right-sided air entry was reduced in the lower lobe. TVS, apex beat is not palpable, no palpable thrills, no murmur, muffled heart sounds, JVP elevated, no precordial bulge. Per abdomen, soft, no guarding or rigidity, no organomegaly, hepatojugular reflex present. Differential diagnosis, anterior mediastinal mass.
Just a minute. Okay, you are telling this differential diagnosis now. Okay, go ahead.
Anterior mediastinal mass, SVC obstruction, to pericardial tamponade, acute coronary syndrome with heart failure, right heart failure, pulmonary thromboembolism, hypothyroidism.
Why you have kept these differentials? What made you think that he's got all these things? Because he's present. Why? First of all, these initial parameters which you have mentioned, they are in emergency department or in ICU?
Emergency department.
Okay, this is before resus or after resus?
Before
Resus, right?
resus.
So you have a hypoxic hypotensive patient coming to you with a proper intact neurology. So was this patient in shock or not?
The BP was 90/51.
No. The question is,
Stop.
you're in intensive care exam. So whether the patient was in shock or not. You have to substantiate your reasons also. Why was this patient admitted to ICU?
Because patient having shock and
So he was having shock.
yeah, shock. That's all.
And the patient was taken to cath lab for pericardial tamponade immediately, sir,
Correct.
for pericarditis.
So this is all outside the ICU.
Yes.
Correct. So nothing is inside
Yes.
the ICU. And inside the by the time, so this is more of an emergency management and what are the definitive management. So he had an emergency and definitive management, right? If this patient was to come in intensive care, what would be the checklist you would have asked for the emergency doctors? So you get a phone call, you are an intensivist on call, you get a phone call, okay, sir, this is a patient of this background, is whatever you have said, and he's got a hypotension, and he's got this heart rate, and he's 88 per minute. So what would you ask the emergency doctor?
Patient
They say about the hypotension and hypoxemia. We look at we look at ABG, sir.
Hmm.
Arterial blood gas analysis, any raised lactates,
Mhm.
and whether the patient was able to become BP is able to normal with fluid resuscitation, any fluids were given or not, sir.
So
And
your approach will be the what you have described, right? Airway, then you will look at the breathing, and then we will look at the circulation. Am I right?
yes, sir.
So how will you ensure that airway was intact? You said patient is
Whether-
oriented, talking, walking, right?
It's a conscious
Conscious, oriented, is able to vocalize well,
okay.
right? There is no
Yes.
other reason for you, no strider.
Yes.
Nice try.
Then what is the next thing? Breathing. What do you look into the breathing?
Tachypnea is the
respiratory rate,
alveolar breathing.
And
axillary muscle involvement,
and
there is any professional.
you will look for the oxygen saturation, na?
Yes.
Obvious, na? You know this,
Yes.
you do it. So what is the first thing what this patient had?
So this patient is hypoxemia, sir. 88% is on room air.
Right. So what would you like to do?
We will get an ABG done and
Give oxygen.
oxygen.
We will give oxygen. So airway, breathing, and then comes the circulation. Right.
Yes, sir.
That's how you do, right?
Yes,
Any
sir.
especially airway, breathing, circulation, you have to make it intact before you do anything. Even to before taking cath lab, if the patient is dead, what you are going to do?
Yes, sir.
Right. So airway, breathing, circulation, that is the primary thing, bread and butter, right? So you will do that.
Yes,
Yes, sir.
Right. So now so airway tick, breathing tick, circulation is hypotensive.
yes.
Yes, sir.
Is it tachycardic? Yes.
Yes, sir.
Cause of
120.
hypotension unlikely, either obstructive or distributive or cardiogenic. Right? Right?
Yes, sir.
So clinically, you felt that he is likely in congestive cardiac failure or right-sided heart failure.
Yes, sir.
Right?
Yes.
What would you do?
Focus.
You would like to do focus, but the focus machine has gone upstairs in the ICU and you are waiting.
JVP, sir. Okay.
Will you fluid resuscitate?
In this session, we will auscultate the patient whether there are any crepitations or not.
Sorry?
We will auscultate the patient for any crepitations.
Yes, so you'll try to determine the what? The type of shock, right? Clinically, you'll try to determine the type of shock, right?
Yes.
How will you determine?
One is by palpating the pulse, whether it is a low volume pulse or high volume pulse.
Okay.
Hypertonic pulse.
Okay.
Or 3D pulse. So that we will see, sir. One. In
Mhm.
blood pressure, whether there is a widened pulse pressure or
Capillary refilling time.
if there is widened pulse pressure, we will look for any septic shock. If not a widened pulse pressure, we will see, sir. And we will examine the jugular veins, sir. Any raised jugular venous pulse pressure. And we'll auscultate for the lungs and the heart, sir. In auscultation of the lungs, whether there are any crepitations, that means it could be a fluid overload state, sir. Or we will auscultate the heart. If the heart sounds are muffled, then it could be some cardiac tamponade causing the obstructive shock. Or if there is a third heart sound, this could be left ventricular failure.
Theoretically, you're right, but theoretically, you would obviously won't doing this. There is one more thing which probably in the beginning you would see. Most of the boxes are ticked, unless Dr. Mukherjee has something to add.
Just we just talk about Dr. Jeevan. We discussed about shock and hypotension, right? So what is the difference?
In shock, there is decreased tissue perfusion because of the low blood pressure, so decreased tissue perfusion and leading to hypoxemia.
Decreased, I think we have to say decreased tissue perfusion. There may be hypotension, there may not be hypotension, right? So if there is an inadequate tissue perfusion, it can be clinical findings like decreased urine output, cold clammy extremity, or can be biochemical parameters like lactate, increasing lactate.
Yes.
And hypotension is there is decrease in the blood pressure, 20% from the baseline. So we'll not use these two terms interchangeably. Okay. And as we discussed regarding the shock, workup of shock, if you are doing clinically, it is better you can mention that cold and warm shock, whether the periphery is cold, whether the periphery is warm.
Correct. That is
Obviously, that will be the initial clinical assessment. You can top it up with your focus assessment. But when you go clinically, try to first step to differentiate between a cold shock or a warm shock.
Perfect. So that is what exactly I was saying. So one thing which you have not ticked when you look at the pulse, you touch the patient, whether the patient is cold or warm, straight away you know partly two shocks you have ruled out. Having said that, you can still get the mixed shock, right? So clinically you will determine, and based on that, because that the clinical things will become what we call it as a, before you use focus, we call it as a pre-test probability. Once you have this pre-test probability of certain type of shock, then you can substantiate using your focus. Going directly on the focus can lead you to a lot of misguided things if you are not involving any clinical examination to start with.
Specifically for exam, you have to go through the clinical assessment. That is a pretty must. Can't say that we'll start with the focus.
Yeah. So when you are asked how will you approach the patient for the differentiating the shock, you have to start with clinical history, physical examination, laboratory investigation, and then focus. Don't say that I will get the focus and do it. Don't do that. You will never get it. Maybe you will be working in some different place where there won't be available focus, right? You have to differentiate.
Also, in case of clinical assessment in critical care, better you always mention ABC first and then you go to there. And then you have to ensure that you are not overlapping or not repeating the same thing as sir mentioned. You're not repeating, but a lot of clinicians, a lot of examiners prefer that you start with ABC, you ensure that, and then you go to the systemic examination.
Correct. So either way up, you have to choose. You don't have to choose all the things. I will ensure in one breath you can finish it off. I will ensure that airway, breathing, circulations are maintained or protected. Airway is protected, breathing should be comfortable, give the oxygen, and circulation, we would look that his shock is addressed by giving the fluid resuscitation in our fluid boluses. Then detailed examination kind of thing, right? Okay. So now you mentioned about the hypotension shock and you came to a differential diagnosis. What makes you think that first differential diagnosis is your anterior mediastinal mass and SVC obstruction? I mean, that's pretty brave for you to put that thing first, unless you have everything in your hand, right? This is a very specific differential, and you put it on the first, on the top.
You can mention what are the positive findings in favor of this diagnosis, differentials.
He had a history of anterior mediastinal mass, atypical carcinoid tumor.
Mm-hmm.
And there is facial puffiness.
But you mentioned systemic generalized edema.
Generalized edema.
Exactly. Edema.
Pitting edema, that also is.
Yeah.
So he can just be a fluid overload state, right?
But that past history of known case of atypical carcinoid mediastinum has made us to think about
Agree.
this one.
Acceptable.
And there is dry cough, and also there is engorged veins in the neck region. So probably we thought of this is the first diagnosis, first differential, sir. And we put pericardial tamponade as the second differential because of this presence of dextride in this case, that hypotension, muffled heart sounds, and raised jugular venous pressure. And and also in the X-ray.
Why hypothyroid?
Hypothyroidism can also present in a myxedema crisis, can present in the similar way of hypotension and breathlessness and hypotension and anasarca or with facial puffiness. So we have thought hypothyroidism also as one of the differential diagnoses.
Which point is against the hypothyroidism? You are talking about myxedema coma, right?
Yes, sir.
So what is against?
Myxedema crisis.
What is what point is against this differential?
In myxedema, there would be non-pit.
Is it just a myxedema? What is the full name?
Myxedematous coma, sir. In that there will be
Patient will
altered
be
medication.
patient will be comatose.
Yes, sir.
And
Here
a
there
patient,
is no.
patient is awake and oriented.
Yes.
Fair enough. So that's
Yes.
And
Okay.
just to point in terms of the differentials, na. So when you say differentials, there are two type of diagnosis. One is clinical diagnosis, like a heart failure, and one is etiological diagnosis, like maybe because of an ACS. Try not to mix them up, because then you find it difficult to explain or from the background disease. Like suppose if you say okay, this patient has a pericardial tamponade, and probably one of the causes can be hypothyroidism. Probably people will not target you. But if you say hypothyroidism is causing everything, it is your primary DD, then things can go little wrong and things can get little difficult.
Yeah.
Okay.
So the way you would present it, the most likely and less likely, as he said. So most likely it's look something in, because given his history, obvious history, I would like to put the anti-mediastinal mass and obstructive obstruction as a top. Mediastinal metastasis, pericardial tamponade, upper coronary syndrome, and cardiac related issues. I will not keep any pulmonary related issues like say tension pneumothorax or those things, because history and physical examination are not suggestive of that. However, I would like to rule out based on the other investigations.
And one more thing you mentioned regarding this is a patient has a syncope and not a seizure. So what are the differential point between these two?
It's no post-ictal confusion in
No,
syncope.
no postictal confusion. Okay. And
In syncope, there is no involuntary micturition and there is no tongue bite or frothing like in seizure, sir.
okay.
And in the syncope, it is just a transient loss of consciousness, which will be within seconds. Patient may come back to the normal conscious levels, and he may not be having the loss of memory of the event, but in
No
seizure
loss
there
of
will be.
no amnesia.
Yes.
Okay. Okay. Please and continue.
Continue.
ECG shows electrical alternates, sinus tachycardia. ABG showing pH of 7.369, PO2 of 81.9, PCO2 of 26.2, bicarbonate of 14.9, and base deficit is 8.8. He is on 5 liter of O2, and lactate was 2.4. So he is on metabolic acidosis and respiratory alkalosis mixed. And on POCUS, large circumferential pericardial effusion with the features of pericardial tamponade. Inferior vena cava was dilated and not collapsing, and right-sided moderate pleural effusion and no shred sign.
So what are the okay, continue. So what are the POCUS findings of pericardial tamponade? You mentioned that features of pericardial tamponade. Can you please elaborate?
Right atrial
There is diastolic collapse of the right atrium, sir. General Kuriakov findings of the
Diastolic collapse of
in
the
this case right atrium, sir.
So when there's a diastole, so RV is dilated, right? So atrium is eventually supposed to collapse.
And there is an increased that duration of that
Diastolic
diastolic
collapse of
collapse.
is it diastolic collapse of the right atrium or
something else?
something else?
Increased duration of more than 0.34 of the entire cardiac cycle, so that diastolic collapse will be.
Can you please repeat? I somehow missed.
Diastolic collapse of the right atrium, that duration of that diastolic collapse is more than 0.34 of the total cardiac cycle, sir.
Is it right?
Forget about the details of things. On a gross, when you see, how will you say that this is a tamponade? versus plain pericardial effusion. You will be able to
Swinging
identify the pericardial effusion, right?
heart.
Right?
Swinging heart.
That is one. Two. This is the exact question what Dr. Mukherjee is asking, but I am asking in a different way.
Is swinging heart, sir.
Okay. Second.
So second one is that diastolic collapse of the right atrium, diastolic collapse of the right ventricle, and there is a respiratory variability of the mitral E velocity of more than 25% and tricuspid E velocity of more than 40%, and IV inferior vena cava plethora of dilation and non-collapsibility, sir.
That understood. But what
There will be echoic, non-echoic space.
Yeah, that you already determined the pericardial effusion with that, right? Echoic space. But then when you are saying with the pericardial tamponade, the features of pericardial tamponade, you should elaborate on that. What is happening and why it is happening. You said the right ventricular collapse or right ventricular what?
Diastolic collapse.
Collapse. What else?
When is the atrial collapse? Is it in diastole or systole?
Early diastole. Early diastolic collapse. In the systole, right atrium will be
So the
contracted.
systole and diastole is related to ventricle. Right. So when basically the ventricle is in systole, so the atrium is supposed to dilate and it's supposed to receive blood. When the ventricle is systole, so it is a systolic collapse of the atrium and the diastolic collapse of the ventricle, rather than the normal response when the ventricle dilates in diastole and atrium in systole. Okay, it is not means when it's a systolic collapse, that doesn't mean the atrium is contracting. The systole and diastole phase depends on the ventricular cycle, not the atrial cycle. Okay, and when you mentioned large circumferential effusion. So how to differentiate or how to objectify that there is a large effusion?
But non-echoic zone of less than 10 mm, 10 to 20 mm, and more than 20 mm. So in a large circumferential pericardial effusion, there will be more than 2 centimeters of the non-echoic zone, sir. So that corresponds to around more than 500 ml of fluid.
All around the heart.
Yes, sir.
All around the heart. Okay.
Yes.
And you are aware of all the windows which will show you all circumferential, right? How would you demonstrate that? Which views of focus you will see? Just views, because you are mentioning about the focus.
I didn't understand, sir.
Tell us the views of echocardiography where you will see all these features of large pericardium circumferential effusion.
Typical view on parasternal long axis.
One,
And apical view, sir.
two, subcostal will help.
Subxifoid view also helps in identifying this, and that also helps in the pericardiocentesis also.
Correct. Do you think that subcostal view has a bit of major advantage over other views in this case? Relatively a major advantage. Not that all will agree on this, but better view in terms of right ventricular physiology.
The subxifoid view, subxifoid is unguided pericardiocentesis also. Subxifoid helps us, so then it could be the more advantageous view.
Yep. Because if you are in a place where there is no cath lab, then this will become a very important landmark technique especially when you have to do it at the bedside. Okay, you may or may not have an advantage of the cardiologist or the cath lab, or sometimes the cardiologist is away and the patient is collapsing. So you need to keep this thing. Okay. Yeah, go ahead. Anything you want to add?
So, and when you mention no straight shine, what do you mean?
So the Shetsin means there is a discontinuity of the pleura and the lung parenchyma, which is a significant of some underlying consolidation, sir.
Okay. And so when there is a right moderate pleural effusion, it is expected to have some collapse of the underlying lung. So how to differentiate between that collapse and consolidation?
Shetsin helps in differentiating, sir.
One is straight shine, okay. More classical. Dynamic air bronchogram. Whenever you try to differentiate between a collapse and consolidation, it's the dynamic air bronchogram that is the main differentiating point. Okay, please continue.
Yeah, you can go ahead.
Easily showing the electrical alternate, sir. Alternating curves.
A1 labs, hemoglobin was 14.2 gram per deciliter.
Yeah, you can skip that. Anything significant you want to talk about?
Specific things, sir, but we have done these to roll out any because he is on already capacitor band. So this is an anti-metabolite. There could be folate deficiencies and so I mean there could be anemia that we have thought, sir, because it is an anti-metabolite. So we thought of looking at those things, sir.
Okay, so there will be anemia and any other finding?
Here hyponatremia is present, sir. 130 sodium is there, and borderline creatinine is there, sir. 1.2.
Is it going to contribute or change your management immediate?
So this borderline creatinine may be helpful, can be helpful of the hypotension may be contributing to that. And in
No,
next
no.
phase,
See, you have already established what is the reason of hypotension was. You don't need a creatinine to tell that okay, the hypotension is there, right? So is this any of this you have done investigation as a routine part of it? That's fine, but is it going to contribute to your further management? No.
any contrast study if needed, then
Are you
creatinine
going to withhold the emergency procedure because your your creatinine is high?
No, sir. No, no, sir. Yes. Okay.
This is an emergency procedure.
Yes.
It is no point in a dead person with a perfect biochemistry. Right. Okay. Next. I'm not saying that you should not be doing it. You will anyway be doing it, but it's not worth discussing at this moment. Okay. This X-ray was done before procedure, is it?
Yes, yes, sir.
So he was hemodynamically stable enough to do X-rays and labs, and then he was taken to the lab. Okay, fair enough. Anything exciting in this X-ray?
I did media presence.
What are the other differentials?
Aortic aneurysm.
No, related to this case.
So,
Related to this case, focus showed you pericardial effusion.
yes.
Right. What is the classical pericardial effusion sign on the chest X-ray?
Water bottle signs. Water bottle.
Is that a
with
water bottle?
Lung fields, clear lung fields.
Okay. So does it fit into your differential?
Not as such, sir. It is not. It is also having other features also, right? Pleural effusion is also present, sir.
Okay, what else it is got? Right pleural effusion till what? There is not much of CT angle right sided, it's slightly blunted and the left side. But do you mean to say that the big shadow and the widened mediastinum, it is there till the mid zone? It is all pleural effusion.
No, sir.
So what are the what is that? What can be that thing?
Inferior vena cava obstruction might have caused this widened mediastinum, sir. In this case.
Why superior vena cava obstruction will cause widened mediastinum? You mean to say that obstruction of vena cava has caused widened mediastinum, or widened mediastinum is one of the cause of the obstructed vena cava?
Widened mediastinum because of that anterior mediastinal mass.
So the another
Yes.
differential is anterior
Anterior
mediastinal
mediastinal
mass.
mass.
So there is a anterior mediastinal mass is another differential.
Yes.
Right? Okay.
Yes.
Next.
Patient was shifted immediately to cath lab for pericardiocentesis. 1 liter of hemorrhagic fluid was aspirated and sent for analysis. Hemodynamically improved after pericardiocentesis. Pigtail left in situ. Pericardial fluid shows glucose of 247, protein 4.8, albumin of 2.8, ADA 16, LDH of 379, and 1 gram stain, no organism was there, and mature lymphocyte and few neutrophil against hemorrhagic background, and no evidence of a typical or malignant cell was present.
So just one thing, when you are sending a pericardial effusion for microbiology at the laboratory investigation, what you are thinking? What are the disease you want to rule out?
Any
Most
infection,
importantly, tuberculosis is the first.
So basically tuberculosis and
Malignancy are the major.
So unlikely it will be a bacterial infection, bacterial pericarditis, except tuberculosis. So very unlikely that you will get anything in gram stain and all. So probably the most important will be a protein and ADA and maybe a malignant atypical cells which will go to flow for further workup. Okay.
It is also more of.
How would you look for tuberculosis here? Which stain?
AFB stains, acid positive bacillus stains.
Correct. It's not a gram stain, right?
Yes, AFB staining, and we may have to send gene expert PCR analysis.
Yes, you have to.
Okay. That's
Yes.
you have to. Anyway, so that means on the day one, when the patient got hemodynamically stable and all those things, so you go for any scan?
Yes,
CT scan or
on the
something?
second day, we
Because
went for
your differential,
CCT test, sir.
Because your differential is not just pericardial effusion, right?
Yes, sir. So
You still got a widened mediastinum. Okay, right. You done that?
yes, sir.
Okay.
Wave 2 breathlessness continued to be there with the requirement of oxygen of 4 liters per minute with nasal pump, and the worsening of pleural effusion to right side was there. So pleural tapping was done, and around 600 ml of hemorrhagic fluid was taken. CCT was done, showing large heterogeneously enhanced soft tissue mass lesion involving right upper lobe, anterior mediastinal mass compressing the superior vena cava at the junction of brachiocephalic junction, and loss of fat plane with the aorta, right pulmonary artery, and right atrial appendages. And Stackford classification to a superior vena cava obstruction, and grade as B, more than 90% obstruction. And Kishi's score was 4.
Having known this CT scan now, Yeah, go there. Next. Having seen this CT scan now, can you comment what are the problems or how do you anticipate airway issues, and how will you manage this?
Yes, sir. On CT, it's showing obstruction of the brachiocephalic trunk. So there is superior vena cava obstruction.
So what are the challenges in airway, breathing and circulation for this patient
In airway,
from intensive care point of view?
the mass is pushing the trachea, so tracheal obstruction is possible, sir. And there could be an laryngeal edema because of the severity of superior vena cava obstruction. So the laryngeal edema could pose a difficult airway issue, sir.
Right. So your difficult airway trolley should be next here, right? What is the worst case scenario here? Complete collapse,
tracheal.
complete collapse of your trachea.
Yes.
Right, and instant death. What is the other circulatory challenge here?
Because of the superior vena cava obstruction, there is because superior vena cava carries more than nearly one third of the venous blood flow to the heart. There could be obstructive shock. There is a decreased flow to the heart, thereby decreasing the left ventricular output and stroke volume, thereby decreasing cardiac output. There is a chance of obstructive shock also in this case.
No, what I meant to say is, what are the challenges in resuscitating this patient?
Because the patient is in hypotension and as already SVC is obstructed, whatever fluid, which the fluid resuscitation is the generally mainstay of treatment. No, sir. In fluid resuscitation, whenever we give more fluid, it may not come to the right atrium and it will not be contributing towards the increasing blood pressure. And this excess fluid can go into the lungs and it can further worsen the scenario, sir.
Why excess of fluid will go to lung? At one point you are saying nothing is entering into the heart. Then how will it go seepage into lung? Then
it cannot contribute to the increasing of the blood pressure, sir. Excess fluid. So
Any comment about the vascular access?
yeah. So I was
Yes.
coming to that. So how will you what vascular access you will give do to this patient? If we ask more detailed question, then it will be a very it's a kindergarten question, but you should be knowing where will you take the vascular access in emergency for this patient.
Femoral line.
Correct. So you will have to get on to a lower IVC and all those things, right? You cannot
Yes.
have it in the SVC.
Yes.
So this picture, this case,
Yes.
it's not a simple pericardial effusion.
Yes.
It is an absolute nightmare and practical challenge to an intensivist in terms of airway and in terms of IV access. Even the peripherally IV cannula in the upper limb is not going to help. The medicines will not reach there. So you need to have either femoral or lower limb access and deal with the issues related to the lower limb access. At least we'll have the surety that it is going to reach the heart and the circulation. Okay.
Yes.
Another point is that regarding the tumor, we are saying this is just one cut, so we need to see the upper part of the tumor, whether it is only in the anterior mediastinum or going up to the superior mediastinum. Because if there is superior mediastinal mass and which can have a potential compression of the airway, then we have a different game, right? In terms of giving anesthesia.
Yeah.
Anyway, position, those things will come in discussion.
Absolutely. The airway anyways is a bit compromised. If you can see, the trachea is already partially compressed there. So you're putting a tube is not going, sometimes it's going to be a terrible and a nightmare, right? So when it comes to a difficult airway, just out of the track, what is the first thing you should do? Anticipated difficult airway, which we never do. Call for help. Call the anesthetist. Don't be brave. That I am also anesthetist. I will do it. No, always call for help as a teamwork. Okay. Next.
Later, superior vena cava stent placement was done and patient discharged after 8 days with anticoagulant rivaroxaban 20 mg once daily.
Suppose this patient has come with anterior mediastinal mass and he had a chemotherapy throughout a day before, and he comes in a shock. What are your differentials?
Please.
So the patient comes in a shock. He is in a vasodilatory shock, right? With acute renal shutdown, multi-organ failure. What are your differentials pertaining to this particular case of malignancy in anterior mediastinum? He comes post chemotherapy.
Pericardial tamponade, hypertension leading to AKS.
Okay, one. You removed the pericardial tamponade by whatever you are doing by the cardiologist, did a fantastic job. It still continues to deteriorate. What are the other investigations you will send for, and that will determine your differential, or what are the differentials, and that will determine your other investigations. This is because you know that this is a neuroendocrine tumor. Suppose you don't know this is a neuroendocrine tumor.
Serotonin. High hydroxyindoletic acid levels will be.
Correct. Or what?
High hydroxyindoletic acid levels will be increased in the urine and blood cell.
Okay, for what? So you're trying to, what differentials you are looking at? It's
Carcinoids.
bad.
Sir?
That is a carcinoid tumor which you are aware. That's why you are saying looking for a carcinoid tumor, right? But suppose you don't know,
Yes,
this is not a this is endocrine tumor. You don't know whether it's an endocrine tumor or not. What is the possibility?
Dr. Jeevan, what happened? Patient will come with this presenting symptom, and after that, we will get a tissue diagnosis. They will come with anteromediastinal mass, superior vena cava obstruction, landing in emergency with respiratory distress, shortness of breath, and you find there is extensive swelling of the face and all. You don't have any tissue diagnosis. So Sally is asking that suppose this patient has come, received some kind of therapy, and now he is follow up with a multi-organ failure. So what will be your DD? Forget about carcinoid. It can be any tumors.
Yes, sir. This could be tumor lysis syndrome post the terrible lymphoma, which could be a anterior mediastinal mass. After that, the tumor lysis syndrome is making the patient into landing up into acute kidney injury. That could be one of the differential in that scenario, sir.
How will you diagnose?
For the tumor lysis syndrome, we apply this Cairo Bishop classification, sir. Cairo Bishop, in that we will having clinical laboratory values of hyperuricemia of more than 8 or more than 25% increase, or hyperphosphatemia, hyperkalemia, and hypocalcemia less than 7, sir. So, and there could be clinical features like cardiac arrhythmias or creatinine more than 1.5 or seizures. Neurological manifestation will be presenting tumor lysis syndrome.
How will you treat?
So for first and foremost is fluid repletion is the mainstay of treatment, sir.
Remember in
for
critical care
tuberculosis.
first and foremost thing is always airway, breathing, and circulation. So before you use the word first and foremost is always the first and foremost. Okay. So
Yes.
tell them if you use this word first and
Airway-
foremost, then the intensivist will be very will not be happy.
Airway, because already that antiremediational mask can compress the.
Leave it. I just commented on your first and foremost word. Don't
Okay.
use first and foremost. Just tell me treatment of tumor lysis syndrome. How you're going to manage.
Okay. So airway patency, securing the airway.
Airway, breathing, circulation done. Next.
Yes. Then fluid repletion to maintain 2 ml per kg per hour of urine output, sir.
Oligoanuric.
Then, yes.
What do you do?
And sir,
Is oligoanuric. What do you do?
one is fluid. Second thing is we have to treat the hyperuricemia with because already uric acid levels are high. So RAS uricase is the in the acute phase. RAS uricase will be helpful to break down the uric acid into allantoin and decrease the uric acid levels. Because these xanthine oxidase inhibitors like allopurinol and febuxostat, they will delay this, but actual uric acid is not being broken down by this. So RAS uricase would be the choice. And for hyperphosphatemia, alkalinization of the urine and phosphate binders will be helpful, sir. For hyperkalemia treatment, we give with insulin and dextrose infusion and beta agonist nebulizations would be helpful.
Okay. So it's a tumor lysis syndrome. It was there. You would have treated him with tumor lysis. That's correct. What is the other differential? He goes in a vasodilatory refractory shock. Post chemo.
Chemo, that could be
Neutropenic sepsis.
Neutropenic sepsis, yes, is not neutropenic. Correct, but that is a differential, and you will go to the pathway of neutropenic sepsis. Anything else? Procalcitonin is not raised, whatever it is.
and
Any other syndrome you know in these kind of malignancies?
second.
You treated that syndrome for 2 years back during pandemic.
So, ARDS, acute respiratory distress.
Cytokine release syndrome is possibility.
Yes,
CRS is possibility, right?
yes, with CAR T cell, CAR T therapy, chimeric.
It's not specific to CAR therapy. CAR therapy might be contributing. It can also contribute into the tumor lysis syndrome.
Okay.
But when you're a MAP therapy or any of this therapy, keep that thing in differential. Tumor lysis syndrome, cytokine release syndrome, HLH. Quick,
Yes.
one word. Treatment of cytokine release syndrome.
Cytosorb.
Fast, yeah, come on.
Yeah.
Treatment of cytokine release syndrome.
Plasmapheresis helps, sir. One is steroid glucocorticoids.
Okay, 1, 2.
Cytosorb filter renal replacement. CRRT with cytosorb.
What did you use during COVID? What did you use in COVID in second week?
IV steroids only.
You use something in COVID? Tocilizumab, Baba. You use solid, right?
Tocilizumab, IL-6.
Then
Yes,
IL-6
sir.
inhibitor.
Yes.
You know this, no?
And before mentioning this, always mention that organ support or medical management, because that is the first line of therapy you will start, and along with that you will put that on. Start with medical support, organ support, or medical management, followed by all those things. And another thing, you mentioned raspberry case. Any investigation you want to send before raspberry case? We usually don't give it to the first line.
Yes.
You are posted.
Raspberry.
You are posted in a South Bombay hospital.
Yes. Raspberry case can cause methemoglobinemia and also G6PD. In G6PD glucose 6-phosphate dehydrogenase deficiency cases, there could be hemolytic anemia because of the raspberry cases. So we need to test for G6 glucose 6-phosphate dehydrogenase.
So probably in a male patient, I will have a lower threshold. For a female, probably I will ignore.
Yes.
Okay. Okay. Continue.
I think the patient got discharged also.
Yeah. Oh, finish. Okay. And regarding tumor lysis, as you mentioned all the province, but when you are saying management, mention one challenge and close the management. Like you mentioned, there can be hyperkalemia. Mention 3-4 point related to hyperkalemia. You mentioned hyperuricemia. Manage to mention 2-3 points related to hyperuricemia. So in that way, you know all the challenges and you are addressing all the problems. So it will be easier to manage.
Correct. And whenever you try to go, don't go into the rabbit hole, and just because you know, you go into the deep. Just because you know management of hyperkalemia, you're talking about urorhype, you come to hyperkalemia, next 10 minutes you keep speaking on hyperkalemia. Okay, that is a very common escape thing. You are supposed to cover as much as possible, as broad as possible. You have to just touch each of them. Management of hyperkalemia, I will go with the pathway of the management of hyperkalemia. No, I will look at the potassium, and then I will give the insulin dextrose, then the beta 2 agonist. Then he will say, oh, why didn't you give it dextrose? How much dextrose you will give? Why are you going for a credit? No, nobody is interested in that.
Yes.
This is why is not going on this. Okay.
Not only that, most of the international exams will have a certain kind of time, okay, that you have 10 minutes to answer everything. So if you keep on expanding on things which are less important, you may not be able to answer things which are more important. Like for the initial ABC, you just mention will ensure ABC, that will be fine.
Yeah, correct.
You don't have to expand that I will put a tube, I will secure the airway, and then we'll go to give oxygen. No need that. We'll ensure ABC and then go to the definitive management.
Correct. But again, you have to smart in that. Suppose if you are looking at this case and this case is more pertaining to a difficult airway, you can't just say, I will secure the airway. Okay. If you feel that the patient is conscious, oriented, coagulate, I will ensure that the airway is patent and thing. If the problem is circulatory, you don't spend time on airway, breathing, and then come to circulation. You quickly come to the circulation. If the problem is disability or neurology, you quickly, so I will ensure airway, breathing, and then circulation, and then if everything is fine, then jump on the thing. In one breath, you have to go, right? At the initial, you will be given the history, and you will get an idea whether this is airway related issue, whether this is a circulatory, because this is a very, very, very typical case. This has two big challenges. One is the airway challenge, and one is the circulatory challenge. So if you fumble on saying that I will take a IV cannula on the peripheral and then I will start infusing the fluid, then anyways, if really the patient comes, you are not going to save him. But at the same time, even in exam, you won't be. It just gets away from your presence of mind. On one hand, you are saying that his IVC is completely collapsed, and then the second hand, you are saying that I will put IV cannula and give IV fluids and inotrops and all that. Doesn't make sense. If you say that no, because I'm suspecting superior vena cava obstruction, I will IV access. Because Dr. Mukherjee had to prompt you specifically that what about the IV access. And the next thing will be I have to anticipate. I will be anticipating difficult airway in this, and difficult airway trolley will be next to me, including the bronchoscope. And cannot intubate, cannot ventilate, cannot oxygenate, cricothyrotomy.
like same thing for the chest X-ray. Suppose we are discussing that X-ray. Obviously, every X-ray will not going to give a definitive diagnosis. You explain that X-ray. There is a homogeneous mass opacity in the right side, and after that, look at ground glassing pattern can be a mass, will followed by ECT, followed by HCT chest, and that would be fine. Rather than keep, because we may not able to get a definitive diagnosis from that X-ray.
Correct.
You understand my point? You have to go to a definitive diagnosis. We have to suggest, we are not going to delay CT by 2 days. We'll stabilize the patient and go to the next definitive diagnosis. You can feel free to say that.
Yes.
Okay. And even in this case, you are not going to say just focus showed a pericardial effusion, but the X-ray didn't show any pericardial effusion
Yes.
features. So obviously, right? The X-ray didn't show any pericardial effusion features. It is more of a bigger mediastinum.
Yes.
Yes.
Right? So if the focus was not there, it definitely would have gone for a CT scan first, then
Yes.
going to the cath lab. Right? Such a
Yes,
big,
sir.
huge mediastinum, you will be thinking more of an obstructive feature because of the mediastinal mass rather than the pericardial effusion. In fact,
Yes.
you can highlight the feature that, okay, because of focus, we were able to get the culprit, which was causing the hemodynamic instability. But the story didn't stop there. Okay. Yeah. That's all from my side. Good. Always go and see the patient and keep clinical things. Don't go directly on
Yes.
the focus. So Mukherjee will soon let you know in details what about the focus.
Sir, any specific points from your side, Sir Sudipta sir?
I think we try to cover all the important points. Dr. Joshi has already covered most of the points. So we discussed two part of the oncological emergency when his patient may present with a malignancy with a tamponade and with a superior vena cava obstruction and tumor lysis syndrome. Another one or two things that we need to read about, that is, one is neutropenic sepsis. Some of the CRS we discussed, that's also a part of the important part of oncological emergency. One is malignant hypercalcemia. We need to know something about dyslipidemia, specifically hyponatremia. A lot of cancer patients present with that, and you have to differentiate between a salt-losing nephropathy and SIAD. In oncology, we see a lot of salt-losing nephropathy. Otherwise, outside oncology, mostly you can say it is a SIAD, but not in oncology. A lot of patients will come with a salt-losing nephropathy. So those things we need to read along with what we have discussed.
Sir, Anand sir, any closing comments, sir?
The oncologic emergency, as Dr. Mukherjee has rightly said, are extremely weird. You have to keep your spectrum very broad than your usual patients. This is only from the practical aspect of it. And however, even though you may get a lot of surprises, but it should not make you jump the queue. Airway, breathing, circulation, common thing, common sepsis, septic shock. Those things will always come first, and then comes with the tumor lysis syndrome, then comes your CRS, and then comes your neutropenic sepsis, then comes your HLH, and then come all those things. Because remember one thing, it is very important, because if by chance you miss the sepsis or obvious bacterial infection and you bombard him with the steroids and the IL-6, then you have already lost the Mr. Bus. So oncologic emergencies are out of when everything is fallen apart. Everything, right from electrolytes to all weird things happening in the laboratory, then probably you're looking at some kind of oncologic. But and the second, last but not the least, again, I always tell this before any kind of thing. Please do not jump on focus if you have not examined the patient. Your pre-test probability will be extremely out of the windows, and sometimes you will be in such a bad soup if you just use the focus. That's where I would close my comment.
Surprisingly, there are no comments and questions from the audience, sir. So I think everyone is clear about the concepts, I think. So with this, I thank Dr. Sachin and Jeevan for bringing a good case for discussion. And I thank Dr. Anand sir and Sudipta sir. In spite of their busy schedule, they have given time to our masterclass and shared their knowledge with our audience across the India. Thank you very much. Have a good day. Good night.
Good night. Thank you.
Thank you both Sudeep and Anand for your presence and time. Thank you.
Thanks,
Thank
Venkat.
you, Venkat, for involving me.
Thank
Thank you,
you.
Dr. Anand. Nice meeting
Thanks,
you.
thanks, Ravi. Same here.
Bye, sir. Bye, sir. Good night. Good night.
Night. Bye.